Since we discussed obstructive lung disease, now let's talk about restrictive lung disease. As you remember from our discussion of pulmonary function tests, restrictive lung disease has a characteristic pattern. As a result of restricted expansion, lung volumes such as FVC and TLC are decreased. But what happens to the FEV1-FVC ratio? Unlike obstructive lung disease, the ratio is usually preserved because patients don't typically have any problems emptying their lungs. They just have less volume to exhale. It's useful to think of restrictive lung disease in two ways. First, think of the mechanics of breathing and the different components involved that aren't the lungs themselves. Can you recall a handful of diseases that result in systemic muscular weakness? Poor muscular effort in conditions like polio and myasthenia gravis result in restrictive lung disease. Similarly, conditions that physically restrict the volume capacity of the lung, such as scoliosis and morbid obesity, which is one of the most common causes, also fall into the restrictive lung disease category. Which category would osteoporosis with the Dowger's hump fall under? Good, the second, restricted physical volume due to the structural apparatus. Interstitial lung diseases, which affect lung parenchyma, are restrictive lung diseases that also negatively impact the diffusion capacity of the lungs. So how do we measure diffusion capacity? Remember in the respiratory physiology talks, we said that carbon monoxide is a gas that is diffusion limited. In other words, this gas equilibrates very slowly across the alveolar capillary membrane, and it is not affected by cardiac output like nitrous oxide, which is perfusion limited. So in this test, we ask patients to breathe an air mixture with a small amount of carbon monoxide. Then we measure how much carbon monoxide is taken up by measuring the exhaled breath. The result is expressed as a percent predicted DLCO, which stands for the diffusing capacity of the lung for carbon monoxide. A low percent predicted value would indicate a diffusion problem that would affect oxygen uptake. Interstitial lung diseases usually cause pulmonary fibrosis, which you can see as honeycombing throughout this image. Examples of interstitial lung disease include ARDS and neonatal respiratory distress syndrome, which we will discuss shortly, and also the pneumoconioses. There's also a long list of drugs that cause direct lung toxicity, fibrosis, and restrictive lung disease. Here's a case of pulmonary fibrosis caused by amiodarone toxicity. Note the fine reticular nodular pattern on the chest X-ray. This is the typical look for most of the interstitial lung diseases. Hypersensitivity pneumonitis, or farmer's lung, is a delayed hypersensitivity reaction to some environmental exposure, such as aerosolized mold or droppings. It leads to an IgG antibody type 3 hypersensitivity and a CD8 lymphocyte type 4 hypersensitivity response in the alveoli. This is not a type 1 reaction like an allergic asthma, and also unlike asthma, this pathology picture shows that inflammation is more centered in the alveoli, as opposed to in the bronchi. Symptoms usually show up 4 to 6 hours after exposure, and you can get shortness of breath, a dry cough, chest tightness, headache, and fever. You may also see bibasilar dry rales and decreased diffusion capacity, or DLCO. If you see the chest X-ray, it may look a bit like atypical pneumonia or interstitial lung disease. In farmer's lung, what's the exposure? It's usually secondary to thermophilic actinomyces bacteria and occasionally aspergillus fungi, especially in moldy hay and compost. And what about bird exposure? Well, this is called bird breeders or bird fancier's lung. This is due to exposure to avian proteins in the dried aerosolized bird droppings. Keep in mind this is not psittacosis, where you have a true bacterial pneumonia. There are many other work exposure conditions related to hypersensitivity pneumonitis, like malt worker's lung and cheese worker's lung, but farmer's lung and bird breeder's lung are the most common and the most likely to be tested. You can treat these patients with steroids, but the main treatment strategy is antigen avoidance. Let's do a flash quiz. What type of hypersensitivity is behind hypersensitivity pneumonitis? Type 3 and Type 4 hypersensitivity. The pneumoconioses are high yield and likely to show up on your boards, so watch out. These pathologic states involve alterations to the normal lung parenchyma as a result of exposure in response to foreign substances, such as coal, silica, and asbestos. Asbestos is perhaps the best known pneumoconiosis, especially because all those late-night commercials. Attention! If you or your loved one has been diagnosed with mesothelioma, you may be entitled to financial compensation. Of course, the lawyers left out bronchogenic carcinoma. So, what is asbestos? Well, it's a silicate mineral that was used for a lot of things, including insulation, fireproofing, and soundproofing. Therefore, you typically saw exposure in industries like shipbuilding, roofing, and plumbing. Unfortunately, exposure classically causes calcified pleural plaques which appear ivory white. In particular, the straight fibers are more carcinogenic than the curved ones. Now, unlike the other pneumoconioses that we will discuss, asbestosis typically affects the lower lobes of the lung. As seen here, the asbestos bodies, or the ferruginous bodies, are basically asbestos fibers that develop a ferritin protein coat with a dumbbell or beaded appearance. Anthracosis and coal miners' pneumoconiosis, or black lung disease, is obviously associated with exposure to coal and its byproducts. The inflammation and fibrosis typically affect the upper lobes, but it can also affect the middle lobes. As with all pneumoconioses, you can expect certain complications, such as right heart failure and something called Kaplan syndrome. So what is that? Kaplan syndrome is a mix of rheumatoid arthritis and pneumoconiosis in people with intrapulmonary nodules seen on chest x-ray in a homogeneous pattern. Silicosis is known as Potter's rot or Grinder's disease. This is a picture of a patient with silicosis and tuberculosis. What's the exposure to look for on the boards? This is associated with exposure to the byproducts of mining, such as foundries and sandblasting. In this disease process, the presence of silica causes the production of hydrogen peroxide and other oxygen radicals that damage lung tissue. Alveolar macrophages take up these particles and release cytokines, such as TNF, IL-1, and leukotriene B4. These lead to fibrosis and the characteristic eggshell calcifications in the hilar lymph nodes. Silicosis is also associated with bronchogenic carcinoma and tuberculosis, which is board testable. Do you recall from the physio section which cells produce surfactant? Type 2 pneumocytes. What does surfactant do? It decreases alveolar surface tension, increases lung compliance, and therefore decreases the work of breathing. The importance of surfactant is highlighted in neonatal respiratory distress syndrome, seen in this x-ray, where pathology is related to the neonate's lack of surfactant. The deficiency in surfactant, due to the immaturity of the neonate's lungs, leads to an increase in surface tension, decreased compliance, increased work of breathing, and ultimately alveolar collapse. On this chest x-ray, you can see these diffuse interstitial infiltrates. So who's at risk for NRDS? Classically, it's preterm infants, especially those born before 35 weeks. Other risk factors include maternal diabetes and C-section. An important marker of lung maturity is the lecithin to sphingomyelin ratio of the amniotic fluid. Both lecithin and sphingomyelin are lipids in surfactant, but it's mostly lecithin, otherwise known as dipalmitoylphosphatidylcholine, that gives surfactant its properties. In NRDS, the L to S ratio is generally less than 1.5, whereas a ratio of 2 or greater indicates a low risk of NRDS. Survival is poor in neonates younger than 24 weeks. Interventions to improve survival include administration of maternal steroids before birth to accelerate lung maturity, intra-alveolar administration of artificial surfactant after birth, and CPAP or intubation with oxygen. However, too much oxygen in the perinatal period can lead to complications, such as retinopathy and bronchopulmonary dysplasia. Will an intubated baby develop retinopathy? No, it's more associated with oxygen tents, which cause initial cessation of blood vessel formation because the oxygen tension in the retina is inappropriate. Once the oxygen is removed, the relative hypoxia in the eye causes blood vessel overgrowth, which can then result in blindness. If the baby has persistently low oxygen tension in the blood, what cardiac complication are they at risk for? A patent ductus arteriosus. Let's do a flash quiz. Silicosis is associated with blank and blank. The answer is bronchogenic carcinoma and tuberculosis. Acute respiratory distress syndrome, or ARDS, has a number of causes related to illness or acute injury. ARDS typically starts off as a patchy process that involves inflammatory cells like neutrophils and some T cells. Cytokines contributing to lung damage include TNF, leukotrienes, and macrophage inhibitory factor. These substances are toxic to the alveolar wall. The result is an increase in capillary permeability and pulmonary edema. The fluid is protein-rich. In this histopath image, you can see inflammation, edema, and proteinaceous fluid here, and hyaline membranes, which is this glassy pink-appearing material when you stain with H&E. So here's a bit of board trivia. In which condition were hyaline membranes first observed? Actually, it's NRDS, which we just discussed. In fact, NRDS is also known as hyaline membrane disease, and in fact, this particular image could pass for NRDS. On chest X-ray, you see diffuse bilateral infiltrates, as seen in this intubated 21-year-old patient with a history of aspiration pneumonia. Management of ARDS has gotten better, but it's still a deadly condition. Mortality rates used to be as high as 70%, but have now dropped into the 30s. Patients typically require mechanical ventilation over a long period of time, with low tidal volumes. However, during the course of treatment, oxygen radicals from high FiO2 levels can cause what's called diffuse alveolar damage, or DAD. So now let's compare obstructive and restrictive lung diseases. This is kind of a quick recap. So as you recall, the FEV1 from the forced expiratory volume over 1 second is influenced by lung compliance and elasticity. Forced vital capacity is the absolute volume of air that can be exhaled. In normal lungs, the FVC1 to FVC is approximately 80%. Obstructed lung conditions, as you can see here, have lung volumes that are higher than normal because of air trapping. Specifically, TLC, FRC, and RV are all increased, and the FEV1 to FVC ratio is typically less than 80%. Can you point out the volumes in this middle diagram? Well, the starting point right here would represent the lung at total lung capacity, which is increased, and so is the reserve volume, which is what you're left with after you've totally exhaled. Where's the functional reserve capacity? Well, that's a trick question. Since this diagram shows forced exhalation, you won't be able to see the lung volume after a normal exhalation. So how would you contrast this with restrictive lung disease? Obviously, you can see a big decrease in lung volumes. That being said, there is a comparable reduction in both FEV1 and FVC that results in an FEV1 to FVC ratio that remains greater than 80%. Note, however, that the TLC in restrictive lung disease is dramatically reduced, and the volume curve is shifted down relative to normal lungs. Pulmonary hypertension is super high yield, so make sure you star this topic right now for later study. Pulmonary hypertension is currently classified into 5 groups, but it's still useful to think of pulmonary hypertension as primary or secondary. First, how is pulmonary hypertension defined? Do you recall from cardiology the normal pressure in the pulmonary artery? About 10 to 14 millimeters of mercury. When do we get worried? when the pressure is greater than 25 millimeters of mercury at rest. So what is primary pulmonary hypertension? Primary mostly corresponds to idiopathic or heritable pulmonary arterial hypertension. Most commonly occurs in women aged 20 to 40. One major cause, although not the only cause, of primary pulmonary hypertension is an inactivation mutation in the gene for bone morphogenic protein receptor type 2, or BMPR2 gene. This is a member of the TGF-beta signaling family, whose normal function is to inhibit vascular smooth muscle proliferation. You can think of secondary pulmonary hypertension as being caused by almost anything else. Take a look at this chest x-ray. The patient is a 38-year-old woman with progressive shortness of breath. There's two things to notice here: the huge pulmonary artery on the right side of the patient's heart and the enormous left ventricle that causes a large mogul. Pulmonary hypertension is associated with a number of other conditions. These include COPD, mitral stenosis, CHF, recurrent thromboemboli, really anything that causes a left-to-right shunt, sleep apnea, living at high altitude, and certain drugs, such as the notorious fen-phen combination for weight loss, that are no longer available, and cocaine. Think for a moment about the underlying disease mechanisms and how each might contribute to the development of pulmonary hypertension. For example, what causes a left-to-right shunt, and what is the underlying pathophysiology? Well, you typically see this with a congenital heart defect, like a VSD, PDA, or an ASD, which causes more blood to flow through the pulmonary circulation to get the same amount of oxygen to the body. And this increased blood flow physically injures the endothelium via shear stress, causing them to become thicker, which increases pulmonary artery pressure. Okay, so how do you treat pulmonary hypertension? Well, first you try to take care of any of the underlying secondary causes. Other treatments that you may have learned about include calcium channel blockers, epoprostenol, which is a synthetic prostacyclin, bosentan, which is an endothelin receptor antagonist you'll hear more about later in the pharmacology section, and multiple phosphodiesterase type 5 inhibitors like sildenafil, or better known as Viagra. What are the long-term sequelae of pulmonary hypertension? Over time, you may get cor pulmonale and right ventricular failure. On physical exam, you would see jugular venous distension, edema, and hepatomegaly. At the end of the day, some patients may ultimately require a lung transplant in order to survive.